Hello, everyone. Thanks for joining us. My name is Sophie Allen, and I'm the marketing coordinator at the Canadian Digestive Health Foundation. I'd like to welcome you to this evening's webinar entitled IBD and Diet. So just a few housekeeping items before we get started. If you have any questions throughout the presentation, please submit them through the Q&A button on the bottom of your screen. If you have a question for a specific speaker, please indicate their name, and we will answer as many questions as we can following the presentation. This presentation will also be made available online at cdhf.ca at a later date, and we will post on our social media accounts and email all those who signed up when it is available. So we'd like to thank Pfizer for the unrestricted educational grant for us to put on this webinar. And I'm just going to go over the learning objectives. So we're going to go over how to explore the treat to target paradigm in IBD, discuss limitations of current therapeutic options in IBD, discuss diet in the development and as a risk factor for IBD, discuss diet as an adjunctive therapy for IBD, and discuss the LifeMD app as an evidence-based support tool to optimize diet in IBD. So without further ado, I'd like to introduce our two amazing presenters tonight to speak on this issue. So first we have Dr. Maitreyi Raman, gastroenterologist, physician nutrition specialist, associate professor of medicine at the University of Calgary, and the director of LifeMD, as well as Dr. Cynthia Seow, professor of medicine, division of gastroenterology and hepatology, departments of medicine and community health sciences at the University of Calgary. So I will pass it off to Dr. Seow, and we will get started.
Thank you so much, Sophie and Kelsey and CDHF for this opportunity to present with my co-presenter, Dr. Raman. So I wanted to give a brief overview about what we're aiming for when we're treating patients with IBD, and then I'll be passing over to Dr. Raman to talk about the specific role of diet. So first of all, when we talk about treat to target, if we go back one slide, what are our targets in IBD? We talk to patients about wanting to feel better. We talk about quality of life, but how do we actually achieve all of this? And it's intertwined into keeping inflammation under control. And I always tell my patients, whether it is medications or other adjunctive therapies, we should be much more concerned about active disease than active therapy, because our goal with all the therapies is to get you feeling better. And so when we talk about this treat to target paradigm in IBD, it's about talking about an end target that will get us to a lack of disability and improvement in quality of life. But ultimately, it's about healing the mucosa. Next slide. So when we talk about treat to target, the first thing is I tell all my patients, of course, quality of life is important. Of course, I don't want you to have symptoms, but that's really only the tip of the iceberg. And whilst we do care and we will ask you about your symptoms, we want to go beyond that, because symptomatic response is only a short-term response. How do we get you into having a durable response to therapy? So on the next click, you'll see that symptomatic remission and normalization of CRP is important. And we do ask you to do regular blood tests. These do check for side effects, and we want to avoid side effects, but we also want to see that your inflammatory markers are getting better. But blood tests sometimes are not sufficient because not everybody mounts a CRP response. And that is why there's been such a big push over the last few years for you to participate with the poop test, which is the fecal calprotectin. And why? Because the fecal calprotectin is really specific to the gut. It tells us if there's inflammation in the gut rather than just your CRP or your blood tests showing that there's inflammation somewhere, meaning that if you have a respiratory tract infection, a toe infection, anything else can make your blood test go up. But the poop test clearly is related to the gut and lets us know whether there's inflammation present. And it also can predict a flare 3 to 6 months before you develop symptoms. And ultimately, the endoscopy, I know nobody likes going for their colonoscopy, but why is it important? Because if we can demonstrate that you have healed the mucosa, healed the lining of the bowel, then we know that long-term, this will normalize your quality of life. There will be an absence of disability. And very importantly, it means that we can avoid flares we can avoid hospitalization, and we can avoid surgery. Next slide. So as we've mentioned, we aim to treat to target because if we can get in there early, there is a possibility that we can change the natural course of IBD. As you know, it starts off with inflammation, just like any other inflammation. If it was on your skin, if you keep scratching it, it will eventually develop a scar. And the corollary to that in gastroenterology is that if you develop a scar in the bowel, it will narrow and you will develop strictures, which you want to avoid. And therefore, if we can heal the bowel early on, we can avoid those long-term complications of hospitalization, surgery. It also means that we're likely not to have to use necessarily more drugs or higher doses, and it reduces the overall cost of care. Next slide. But often there is a gap despite the use of medications. And we often hear from patients that I've still got symptoms, even though you tell me that my gut is looking well. And yes, with UC, we focus on symptoms such as rectal bleeding and stool frequency. But with Crohn's disease, there is a focus more on abdominal pain and stool frequency. So how do we reconcile that gap? Next slide. Firstly, our therapies aren't perfect, but know that many of us, especially working at the University of Calgary, Maitreyi and myself, and other universities, we are all researching better therapeutic options for our patients. We know that some patients will remain symptomatic because we haven't controlled the disease properly, and that's why it's important to come back for regular review so we can optimize therapy. Very often, we know that patients have coexistent irritable bowel syndrome, where there may be ongoing symptoms despite the bowel looking like it's healed. And I think that Maitreyi will cover this as well, that dietary therapies can help both with inflammatory bowel disease as well as irritable bowel syndrome. So you are what you eat, and knowing how to control that better may help out with your symptoms. Obviously, other psychological issues need to be addressed, and we always address mental health with our patients because we know that chronic disease can have an impact on anxiety, can have an impact on depression, and that can in turn lead to more symptoms. And there might be adjunctive therapies that are needed to improve quality of life. And when I talk about adjunctive therapies, I want to make that distinction that these are complementary therapies. We use them in addition to the medications that we are prescribing. I make the point that they're not alternative therapies. They're not instead of using prescribed therapies that are known to change the course of disease, but they are helping out. And that includes the role of diet, exercise, psychological care, spiritual care, naturopathic medications. We are not against them. We just feel that they are complementary or adjunctive therapies rather than an instead of. So with that kind of introduction, I'd like to pass over to Dr. Raman to talk about how we can use diet to help us achieve that ultimate goal of mucosal healing and getting rid of symptoms and improving quality of life. Thank you.
Thanks very much, Cynthia, for that excellent background. And I'm delighted to be able to talk to you all today about the roles for diet and nutrition and why these are important to consider in IBD. So today I'm going to review the spectrum of diet and nutrition therapies that may be relevant to a patient diagnosed with IBD, talk about whether diet indeed can be a risk factor and can be utilized together with usual medical therapies to improve the course of IBD, and then talk a little bit about nutrition and malnutrition, as well as micronutrient deficiencies, and then talk about some novel strategies that may be utilized to bring this all together. So the spectrum of nutrition, diet and nutrition in inflammatory bowel disease is actually quite broad. So this can range from malnutrition or undernutrition that can affect between 20 and 85% of individuals diagnosed with inflammatory bowel disease. And malnutrition can refer to both protein and energy malnutrition, as well as deficiencies of vitamins and minerals, and if present, can lead to a lot of unexpected and unwanted side effects, such as muscle loss, fatigue, as well as have an impact on worsening inflammation as well. And then the other side of the coin is that malnutrition and undernutrition may occur in up to 50 to 75% of patients, but equally important is that carrying extra weight and having overweight or obesity can also limit usual medical therapies from working to their maximal effect. So understanding if there is a component element of malnutrition or overnutrition are important to identify, as this can have important impact on your current treatment strategies. Now, in the middle of it all is the question around what you should eat. And diet and dietary patterns, as well as nutrients, can alter the inflammatory course in the gut. So understanding where dietary interventions may fit to help improve the effectiveness of our usual medical therapies is an important point to understand and consider. Now, when you ask a group of 400 patients who have been diagnosed with IBD their perspectives on diet and nutrition, the responses are quite telling. Up to 50% of individuals felt that diet could, in fact, initiate their inflammatory bowel disease. And 60% of patients felt that it could either trigger a flare or they reported worsening symptoms with certain foods. And this may relate back to the point Dr. Seow made around having IBS overlap, which may factor into this finding. Now, all of this together has led to about 2/3 of individuals who have deprived themselves of their favorite foods in an attempt to try and prevent disease relapse. But despite it all, only 50% of patients received formal dietary advice, with the other half not being formally discussed on this topic. So I'd invite you to reflect and think about whether you've had questions about diet and nutrition and how you've sourced information on this topic, and whether you proactively bring up this conversation in your clinical visits. So first, can diet cause inflammatory bowel disease? Now, this slide I borrowed from our colleague, Dr. Gil Kaplan, who did a beautiful job in describing how the prevalence of inflammatory bowel disease has changed over time. So you'll see on the far left that the first case of ulcerative colitis was diagnosed in the mid-1850s during the Industrial Revolution in the UK. And then over the course of the next 100 years, there was a rapid rise in new cases of inflammatory bowel disease involving westernized nations. Now, the first case of IBD was reported in 1956 in China. And then over the course of the next 50 to 70 years, we're seeing a different change in paradigm. We're seeing that newly industrialized countries are sort of now being seen to have more increased cases. So the prevalence in newly industrialized countries has risen. And this, we think, is part of the globalization and particularly environmental factors, which now are thought to have a role in the development of new cases. And when we think about the environment, diet and dietary patterns, of course, have changed dramatically over the past 50 to 100 years, and newly industrialized countries are largely adopting Western dietary patterns. This potentially may have a role to play. Now, I'd like to take you back about 10 years to the Nurses' Health Study. And in 2013, this was a landmark study at the time, whereby 170,000 healthy women were followed up over 26 years. And in this time period, there were about 500 new cases or so of either Crohn's disease or ulcerative colitis. And all these individuals kept really rigorous data and food diaries about food components and dietary patterns that they engaged with during the time they participated in the study. What was really telling was that higher intake of dietary fiber was associated with half the risk of developing new onset Crohn's disease. Now, interestingly, the same finding was not observed in ulcerative colitis. But within the Crohn's disease patient group, what they identified was that not all sources of fiber were considered equally protective, with the greatest benefit coming from fruits first and then vegetables, with grain-based fiber having a lower protective role. Now, this slide is a little bit busy, so I'm going to walk you through it. But this, the previous study came out of the United States, and this study came out of Europe, whereby 80,000 healthy individuals were followed up over a course of 20 years. And here again, there were just over 500 people who eventually developed inflammatory bowel disease in this follow-up period. And what they identified was that people that followed more closely a Mediterranean diet compared to those that did not follow a Mediterranean diet were significantly protected from developing new onset of Crohn's disease. Again, oddly, the same finding was not observed for ulcerative colitis in this particular study. So the authors concluded that potentially having a Mediterranean diet-like pattern may confer some level of protection for Crohn's disease onset. Now, more recently, this was a global study that involved more than 150,000 patients, and, or I should say 150,000 healthy individuals that were followed up over 20 years. And there's been an interest in trying to determine whether processed foods and or food additives may have a role to play in the development of new IBD. And relevant findings from this study included that consuming more than 5 servings per day of processed food was associated with an 80% increased risk of developing IBD compared to an individual that did not have any processed food intake at all. And to break it down further, intake of more than 3 servings per day of soft drinks, sugar and sweets consumption more than 100 grams per day, and salty foods or snacks more than 100 grams per day were all associated with double the risk of developing new inflammatory bowel disease. So collectively, these large studies conducted over long periods of time suggest that diet may be an important risk factor for developing new IBD and maybe one potential area for modification if an individual is thought to be of higher risk. So my next question I'd like to discuss is the following. So can diet be used to treat IBD together with usual medications? So here I'd like to highlight that there have been several different types of diets that have been studied in some shape, way, or form in inducing remission or maintaining remission in patients with inflammatory bowel disease. Now, in the last 5 years, 3 of these diets have been subject to higher quality research type methods, and these include the top 2 on the screen, the Crohn's disease exclusion diet, the Mediterranean diet, and the specific carbohydrate diet. The other diets listed here are either under investigation or have not yet been subject to more rigorous types of methodology. But what we can conclude is that the Crohn's disease exclusion diet, Mediterranean diet, and specific carbohydrate diet all have an important role to play in improving symptoms. And in fact, in all of these studies, symptoms did improve fairly substantially. But as Dr. Seow mentioned earlier, symptoms are definitely an important endpoint, but as important as it is to manage symptoms, it is equally important to manage underlying inflammation. So a burning question is, well, can these diets actually impact the inflammatory course in the gut? And what we see is very interesting. We see that similar to the fact that not all patients respond to all biologic medications, similarly, not all patients respond to all diets. So it's work in progress that both Dr. Seow and myself and others are doing are to try and personalize the therapeutic strategy to the individual based on their biological factors. So one point that's emerging is that understanding the bacteria that live in your gut, the microbiome, is an important factor of determining response to diet. So potentially having what we may consider a healthy microbiome, one that is capable of appropriate digestion and metabolism of the food products that it's fed, potentially can harness an anti-inflammatory response. So at a high level, we can say that the Mediterranean diet and the Crohn's disease exclusion diet have a role to play in improving inflammation, but these should be used together with usual medical therapies and not independent of medical therapies. So if usual biologic medications can improve inflammation in, let's say, 2/3 of individuals, Potentially adding in diet therapies can boost that response even further. Now, when we choose a diet, it's important to consider the following. Is the diet feasible? So if your diet is highly restrictive, it may not be possible to adhere to a diet for a meaningful length of time. So having a diet that's fairly broad with limited exclusion or components that are excluded will be critical to maintaining success. So for example, a restricted diet may lead towards nutritional deficiencies. And in an individual that may already be at risk for nutritional deficiencies, we may wish to focus more on a broader diet with less limitations like the Mediterranean diet. But if an individual is nutritionally complete and they are not malnourished or at risk for malnutrition, exclusion diets can be considered, like the specific carbohydrate diet or the Crohn's disease exclusion diet, given that there are data for improved inflammatory course. So there are many components that we have to consider when we embark on a diet. We need to set our goals as to what our expectations are for diets, and then with your gastroenterologist, choose which option is right for you. Now, some research that we're doing relates back to the relationship of various dietary components and how they relate to the stool marker calprotectin and the systemic marker of inflammation, the CRP. Now, in a group of 40 patients that we followed over time, we identified that increased intake of leafy green vegetables was related to low fecal calprotectin levels of less than 100. Similarly, we found that an optimal ratio of omega-6 to omega-3 polyunsaturated fat profile was associated with lower C-reactive protein levels. So collectively, these types of foods are related to lower rates of inflammation. Now, other groups have done similar types of work, and they've identified that specific types of fat may also be related to inflammation or lack of or lowered rates of inflammation. So we've taken the various data points in the literature and developed this first IBD food pyramid, which was recently published in medical journals. And this food pyramid can be used in the clinical environment, and you can discuss it with your gastroenterologist when you see them to try and understand how it applies to you. So this food pyramid has 5 major priorities for consideration. At its foundation, or priority 1 behaviors, are focusing on intake of multicolored fruits, vegetables, and leafy greens. I've shown you some data around how leafy greens can be related to lowered inflammation, and we've discussed about the gut bacteria and how this can be shaped in a way that could be favorable to improving the inflammatory course. Fruits and vegetables and starchy foods and legumes are able to modify the microbiome in a way that can promote health. Now, there are also some data that suggests that processed foods, I've shown you some data today, as well as food additives, how these can also impair the leakiness of the gut. And focus on minimizing food additives as well as minimizing processed foods, and a focus on homemade meals may also facilitate improving additional food triggers for inflammation. Priority 4 behaviors are a focus on healthy proteins, and these can be optimized through fatty fish as well as white meat and nuts and seeds when tolerated, with lower emphasis on red and processed meats. And then final priority 5 behaviors are to choose healthy fats like extra virgin olive oil, which are rich in vitamin E, which have strong antioxidative properties. Now, listening to this, you may be thinking, well, I've tried fruits and vegetables and they bother my gut, and I have some bloating and cramping associated with that. And of course, if that's the case, then these recommendations need to be personalized to what you're able to achieve in a safe and meaningful way. And just a side note about changing textures and blending foods, as well as peeling skins and removing seeds when possible, are all interesting and effective tips and tricks which may make the implementation of this food pyramid work for you. So now I'd like to talk about whether there's a relationship between IBD and malnutrition. And I think at the beginning of this talk, I did indeed indicate there certainly was. Now, when we look at all people admitted to hospital, not just with inflammatory bowel disease, but for any reason, including heart and lung problems, we see that about 45% of people experience either moderate or severe malnutrition when they're in hospital. But this is rarely recognized. In patients with inflammatory bowel disease, there is a higher risk of malnutrition, especially during the period of hospitalization, which can reach between 75 to 90% of patients. And even in the absence of hospitalization, if you're an otherwise healthy patient that happens to be diagnosed with Crohn's disease or ulcerative colitis, there still is between 20 and 30% chance of experiencing malnutrition, whether one is aware or not. And it's important to recognize it because malnutrition is associated with increased infections, so lung infection, wound infection, urinary infections. It's associated with increased length of stay in hospital. And then once discharge from hospital has occurred, it can also be related to increased readmission rates to hospital. And then if you've had a surgery, malnutrition is associated with wound breakdowns, leakage at the surgical site, and bleeding from the surgical site. And importantly, it can also be associated with decreased effectiveness of your biological agents. So understanding if malnutrition is present provides an opportunity for treatment, which can then be addressed and can be used to support holistic care. Now, further, around malnutrition, we typically think about weight loss or change in food intake or limitations or avoidance of food groups. But micronutrients, as I've alluded to earlier, are also an important component of malnutrition worthy of discussion. Many people may have undergone various surgical resections whereby parts of their small bowel may be removed. And you see on this figure on the right that various nutrients are absorbed in specific areas in the gut. And many patients with Crohn's disease may be deficient in iron, calcium, magnesium, copper, B vitamins, as well as electrolytes such as sodium, potassium, and magnesium. And deficiencies in these can be associated with a wide variety of problems. And these deficiencies can occur because of diet restrictions or avoidance of whole food groups. They may come about due to active inflammation, or they may come about due to surgical resections. So being aware if you're at higher risk or not is important because this can be considered in your treatment plan. And having deficiencies in these micronutrients can be associated with poor bone health, with muscle mass loss. It's been associated with increased risk of blood clots, as well as abnormalities in immune regulation, as well as conditions that are outside of the gut. So they can be involved in impairment of heart health as well. So following balanced diets like the Mediterranean diet, avoiding blanket food restrictions, and being aware of higher risk situations like active disease, prior surgery, ongoing high losses through diarrhea or vomiting or fistulas can be important to be aware of so we can test for deficiencies and treat them without undue delays. Now, many of you might be familiar with your typical GI appointment. Now, this is presenting a scenario whereby you're a new patient to your gastroenterologist. And in a new patient situation, your gastroenterologist may have about 30 minutes to spend with you in the clinic. And there's a lot of ground to cover, obviously, because there's so many factors of your health that are competing for time. So the typical breakdown for any individual might be slightly different, but in general, most of our time is spent discussing with you, the patient. We try and understand your symptoms, how you've dealt with your symptoms to date, what kinds of therapies you've tried, what your major pain points are at the present time. And then we like to discuss our investigation approach. Do you need a colonoscopy? What other investigations might be required? And the heavy lifting in the clinic time usually centers around the variety of treatment options, the biologic agents, the pros, the cons, the side effects, the monitoring. And at the end of this period of time, we are really left with very little time or even no time to discuss many of the things on the outer box of this slide. So we may talk about smoking cessation as well as discontinuation of medications which may cause further problems like Advil and other non-steroidal anti-inflammatory agents. We talk about vaccinations, but we may spend less time around the role of diet or weight management, sleep optimization, physical activity engagement. Many patients do complain of fatigue type symptoms. And then the brain-gut connection is very important in inflammatory bowel disease because there's some emerging data to suggest that potentially depression and anxiety may in fact be of inflammatory origin. So we understand that these are several different components of care which are very relevant to the GI patient, but oftentimes limitations in time as well as accessibility and resources may lead towards not having as thorough a conversation as one would like. So to try and fill that gap, we have developed a mobile application called LifeMD, and this is downloadable at no cost from the Google Play Store or the App Store, and anybody in the country can access this at no cost. And the LifeMD application is designed to provide patients with digestive diseases a personalized evidence-based program. It was initially developed for patients with Crohn's disease and ulcerative colitis, but now there are other reasons why people may use it. And the goal of the LifeMD application is to harness the power of nutrition and lifestyle therapies that have been demonstrated to improve disease and that have validated evidence and published, which have been published in the literature. It's a tool to help guide and supplement your usual care that you will receive from your usual IBD care team. And the LifeMD application is designed to fill some of these gaps in care. It does provide personalized recommendations based on where you are at in your journey. There are over 150 to 200 recipes to practically implement to action some of these items. And as you see here on the screen, there's also a live in-app coach chatting section whereby you can interact with the health coach who can help understand your priorities, your pain points, and help put together a nutrition and behavior change lifestyle program to help supplement and complement your usual medical therapies. So in addition to diet and nutrition, there is a full yoga, breathing, and mindfulness program to fully connect the brain and the gut. There is also a gut hypnosis program for individuals that are interested to help manage their IBS overlap symptoms. There is also a physical activity program to assist with weight management and with mood and mental health connections. And as well, finally, there's a full cognitive behavioral therapy program, which you can use either self-supported or supported by the health coach to help tie in all of your competing medical concerns together. Now, we have experience in using the application in almost 600 patients so far, and we see that patients use the LifeMD application to learn what to eat because they wish to have more energy, to better manage their disease. They want an evidence-based program and to overall improve their health. And overall, close to all patients who have participated with the application felt that there were changes that they could identify to improve their health. Close to 90% of people felt the program has improved their life in some way, and close to 70% of patients felt that they would recommend the app to a friend. So if you're interested in this approach to help support your overall care, you can download the application from the store, the App Store, or from the LifeMD website. and then you will be asked to sign in with your email address, and then you will select a password. You'll need to go to your email to validate that it was indeed you that did request this. And then once you've validated it, you will require a subscription code to be able to log into the application. And you can get the subscription code from your patient support coordinator, or you can email info@lifemd.com to get a subscription code to access the program at no cost. And this sign-up process is required so that we can get some information about you with your consent, so we can tailor the program to make it most useful for you as an individual. So with that, I'd like to conclude. Oh, sorry, I think I have gone too far, and I'll see if I can get back. Maybe not, but I'd like to conclude by thanking you for participating and for watching today, and also just for reminding you that there are many roles for diet and nutrition, and this area is growing. It's a subject of research, and I'm happy, as I'm sure Dr. Seow is as well, to take any questions.
Yes. So thank you both for sharing that very important and informative information. If anyone has any questions, please put them in the Q&A chat on your screen, and we can answer them. Just give it a minute in case anyone's typing. Oh yes, here we go.
And maybe in the interim, I'll just chime in and tell patients that exactly what Dr. Raman said. It's not that we don't see diet as being important, but sometimes just in a very busy clinic appointment, we can't cover everything. And I'd always tell my patients, advocate for yourselves. If you have questions about it, whether it's about diet or the role of exercise, the role of complementary therapies, please do ask. We do focus as physicians on medications, on inflammation, but they all have a big role. So we also, many people that help out in clinic, as you well know, in terms of dietitians, counselors, you know, we have a good working relationship with them. They're also busy, but just feel free to ask, because there is support available in person as well as online, as Maitreyi has discussed.
All right, thank you. So I have our first question. It comes from Tom, and Tom asks, how does the additional dilemma of having rheumatoid arthritis impact this presentation, or does it?
I wonder, Cynthia, if you would be keen on sort of talking about it from a mechanistic perspective, and I'm happy just to jump in with the dietary relevance.
So Tom, thanks for your question. I think the important thing to know is that there are many immune-mediated inflammatory disorders. And unfortunately, with inflammatory bowel disease, you know, we are gut-centric. So we say that the joint issues may be related to the gut. And that's why we give terms like enteropathic arthritis, which just means that it is inflammation of the joints related to the gut. But if you speak to a rheumatologist, a joint doctor, they will say that the gut is secondary. But essentially the gut, the skin, the joints are all related, and ultimately it is important to reduce that inflammation. And that is why there is marked overlap in the medications that are used between rheumatology, dermatology, as well as gastroenterology. And so reducing that inflammation with medications is important. But similarly, as Maitreyi said, there is a role for diet. In addition to the inflammatory component, Dr. Raman also mentioned about weight. If there is excess weight, that affects the joints too. So there's lots of mechanisms in which diet may have a role with other immune-mediated disorders, but ultimately asking your gastroenterologist to speak to your rheumatologist and dermatologist, we're usually all working together. Comments, Maitreyi?
Cynthia, that was an excellent answer. I agree with all of that. And then I think to very multi-components. So we talked a little bit about the gut microbiome, and we think that the gut microbiome potentially could have implications on development for both inflammatory bowel disease as well as rheumatological inflammatory arthritis. So the important thing, which is I think of interest to the rheumatologists, they seem to be learning from the gastroenterologist that further study into the role of diet is important. These studies in rheumatology have not yet been completed. I think it is a priority area for them, and we probably will be seeing some studies, more rigorous studies around the diet and nutrition components for rheumatoid arthritis emerge over the course of the next few years. Right now, the rheumatologists also do think that the Mediterranean diet may be a starting point if one is interested to integrate dietary therapies into their usual, into their care plan together with their biologic agents.
Thank you. Our next question comes from Darlene, and they are asking, who orders the special blood and poop tests?
Okay. Yeah, these can be ordered by your family physician, but most commonly it's ordered by the gastroenterologist. It is part of our standard of care to ask, as we mentioned, about symptoms, correlating that with blood tests, correlating it with, poop tests if the patient has inflammatory bowel disease, and ultimately doing that endoscopy. So it's all part of a package, just as everything that we mentioned today is multidisciplinary. I think it's important that there is good communication between your family doctor as well as your gastroenterologist. If you are on medications, even if you're not, it's a form of monitoring. So please engage with your gastroenterologist about it.
Thank you. Our next question is, what diet is recommended for UC?
So that one is interesting. So we are seeing more studies, and historically there have been more studies in Crohn's disease, and I'm not entirely sure why. But I think patients diagnosed with ulcerative colitis have also noticed this gap. So there is work underway to be able to better answer that question. But in the last maybe 2-3 years, we can also say that the Mediterranean diet has a positive impact on ulcerative colitis from a symptom perspective. So Dr. Seow talked a little bit about rectal bleeding, as well as frequency of bowel movements and urgency. And Mediterranean diet has been shown to improve those symptoms. And what's really interesting about ulcerative colitis, it also seems to be fairly fiber responsive, perhaps more so or in a different way than Crohn's disease does. So prebiotic fiber supplements. So prebiotics are dietary fibers or undigestible carbohydrates, if you will, that once consumed orally, they flow through the GI tract, and they're able to shape the gut microbes in a way that can facilitate health. This is in contrast to probiotics, whereby an individual consumes the actual bacteria. So the prebiotics are the fibers. And the prebiotics do show some improvement, particularly in the calprotectin as well as the endoscopic disease activity. So generally speaking, if diets in fiber or if fiber-rich diets can be tolerated, soluble fiber-rich diets that are rich in polyphenols, which are basically, they come from multicolored fruits, vegetables, berries. They include things like antioxidants, as well as bioactive compounds. These types of foods can really fuel the gut in a way that can help improve the inflammatory course. So is there a diet for ulcerative colitis? I would say that probably still Mediterranean diet would be the one to consider, but experimenting with some of these food items that I've described could add an additional level of success.
Amazing. So our next question is, how does Purine affect fiber content?
Yeah, so that's a good question. So Purine, when you maybe I'll just take a step back. And so when you heat foods or expose foods to heat, so you boil, broil, bake, however you want to modify it, it does decrease the insoluble fiber content. So fiber can either come as an insoluble fiber source or a soluble fiber source. And insoluble usually means you consume the fiber and it goes through the gut, and then you basically pass it in the stool or you poop it out. It doesn't have much metabolic potential. But a soluble fiber is you eat it, it goes into the bowel, and the bacteria there can degrade it and liberate healthy compounds. So typically, if you're unable to tolerate fruits and vegetables and you expose it to heat, by degrading or by changing the insoluble fiber content, it helps you manage it or tolerate it more effectively. Now, pureeing, what it does is it changes the transit with which it moves through the time that it moves through the bowel. So typically when you drink fluids, you are able to it moves a little bit more quickly through the gut. When you eat solid foods, it stays in your stomach for a little bit of a longer period of time. So by pureeing the foods, what it allows the liberation of nutrients and content at a more regulated pace throughout the gut. So it does allow you to tolerate it more effectively. So it doesn't necessarily change the fiber content, but it changes how you respond to it from a symptom perspective.
Mhm.
Okay, just dropping in here for Sophie. Another question from Wendell was, what is the role of probiotics with IBD?
Cynthia, would you like me to start and then I'll pass it over?
Absolutely. Yeah.
Great. So probiotics have been studied in both ulcerative colitis as well as Crohn's disease. And there is a signal for benefit in ulcerative colitis. So probiotics like E. coli Nissl, for example, and BioK Plus seem to have similar effectiveness on addressing the colonic inflammation in mild to moderate disease, similar to agents you might be familiar with, like the 5-ASA compounds. So Salofoc or Azocol, Mezavant, these are all usual medications that we would start using in a patient with ulcerative colitis. So we would think, or the data would suggest that potentially probiotics may have a similar level of effectiveness, maybe potential, I think in clinical experience, maybe a little bit less than that, but there may be a role certainly to combine probiotics with, or specific probiotics with 5-ASA therapies. Now, the effectiveness for Crohn's disease is much less well proven. And I would not typically recommend that we think about using probiotics for Crohn's disease unless we're using it for a different reason. And there are other reasons which may benefit from probiotic use, but not for overall disease management in the setting of Crohn's disease. And the lack of effectiveness from the clinical trials probably relates back to the fact that we don't know what bacteria we're trying to increase. The subject of the gut microbiome is really still very heavily being researched. And I think when we understand what are the right bugs that should be living in the gut, in what combination, in what volume or abundance, I think we may be able to design a probiotic that can achieve those goals. But at this point, we don't have enough information to be able to do this properly. So for that reason, I wouldn't recommend routine probiotics for Crohn's. Cynthia, I'd love to hear your thoughts.
Yeah, and I'd just like to add that, again, all of these components, whether it's prebiotics, probiotics, other dietary therapies, other complementary therapies, whether that is cannabis or other things, these are used often adjunctively, as we've mentioned before, with standard therapies. And I know that many people say, well, I don't want to be on medications, but as we've said, patients should be much more concerned about the effect of active inflammation than active medications. The medications that have been, licensed for use, specifically in Canada, has a very rigorous very strict way of releasing these medications, and they have been very well studied, and they would not be allowed to be used if we didn't think that their benefit didn't exceed the risks. So I think whilst there are many naturopathic and other complementary therapies, they have not been studied as rigorously as the medications. So I think that that should still be the backbone of therapy.
Great, thank you. So the next question is, do you have any suggestions about how to get in leafy greens if eating salad creates problems?
So that is a great question to work with your dietitian. And usually, and so like was mentioned before, a multidisciplinary team approach to be able to land on a personalized program for you is really critical. So as a gastroenterologist and physician nutrition specialist, our role is best to try and identify which diet, what are our goals, what period of time should you try these diets on, how are you responding to them, similar to how we would measure response to your usual medications, and then how we can try and tailor or land on the dietary program that's optimal for you. Now, definitely there are going to be questions about, well, specific foods may cause me problems. I may have more bloating or gas or cramping. How do I go about making it work for me? This is where I find I rely very heavily on our dietitian colleagues to be able to provide the troubleshooting and the practical implementation to answer that exact question. So the issue that sometimes we may encounter is that inflammatory bowel disease is a fairly specialized condition, and the dietitians often have experience in very broad areas of practice. So finding a dietitian that has expertise in inflammatory bowel disease and is used to, and someone who has experience and expertise in this particular group of patients is really important to try and find, so that they understand the challenges that you face and have the experience to be able to guide you in answering those questions.
And I'll just put in a plug in there that, really ultimately we as physicians are into personalizing care. So when you have these concerns, please bring it up with your physicians, because we do want to make sure that you are on a therapy that is working for you.
Thank you. Our next question is from Diane, and they're asking, if you have Crohn's and IBS, is diet different for each?
Okay, so I can start and I'll hand it over to Dr. Seow. So yeah, that is definitely, that definitely does happen. So IBS overlap with Crohn's disease can happen up to 30%, maybe even more cases. So, and oftentimes this is the real dilemma we encounter on a regular basis. How much of your symptoms are related to active inflammation versus IBS overlap? So here, this is a tricky question, because we, like Dr. Seow mentioned earlier, we always want your symptoms to be optimally managed. So depending on, I would say that there are differences between IBS diet as well as IBD diets. IBS diets have been investigated perhaps more rigorously and over a long period of time. There's high quality data to suggest effectiveness of specific diets like the low FODMAPs diet for patients living with IBS. But the low FODMAPs diet has been also studied in inflammatory bowel disease, and so far there aren't any signals that this modifies inflammation. But does it modify symptoms? Surely it does. So if we implement the low FODMAPs diet, likely you will improve your GI symptoms, the bloating, the cramping, the diarrhea, and all of those types of symptoms. But it's important to understand that it probably will not have any impact on your inflammation. So again, to reinforce the point of sticking and adhering to your usual therapies, that's really important. But I'll also put in a plug and say that the low FODMAP diet is one established dietary therapy, but the Mediterranean diet also has been shown to have effectiveness in IBS, but just not as well researched. So if we're looking for a combined strategy for both IBS and IBD, I would suggest the Mediterranean diet. Cynthia.
I would just echo exactly what you've mentioned, Maitreyi, again and again, to say that some of these complementary therapies have not been shown to reduce inflammation to the same degree that medications can, and that's why it's complementary.
Okay, we're just going to take one more question from Diane. And do you have any suggestions for cow's milk versus alternatives for when in a flare?
Right. So, the conversation around milk and dairy is interesting. I think that many patients with Crohn's disease are at risk for lactose intolerance, and following a low lactose diet can be effective, especially if you're very symptomatic. But having said that, there is also some data. So I'd shown you that this slide very briefly about the various types of fatty acids and how they can be associated with disease relapse, so with more inflammation. And this fatty acid, myristic acid, is actually highly represented in dairy products. So there is emerging data to suggest that milk cow's milk may have some pro-inflammatory properties. Now, I don't want to make overarching or sweeping statements because there are so many benefits so many nutritional benefits that can arise from consuming milk-based products. But I think if you feel that you are not tolerating it, then it is very reasonable to at least take a pause on cow's milk, keeping in mind that the culprit may not be the lactose, but it may actually be the milk protein. So for that reason, I would eliminate or not elect or opt for low lactose or lactose-free options, but eliminate milk completely, at least for a short period of time, and then try and reintroduce it once your disease is under more optimal control. And I think your question was around alternatives. So the alternatives are going to be tricky because when we think about the primary nutrients that we get from milk-based products, these are usually calcium as well as vitamin D. Now you can replace these with supplements up to a limit because there is danger in exceeding specific thresholds of calcium intake because it can pose a concern to heart health. But if we're specifically talking about things like almond milk or soy milk or other forms of non-dairy milk containing products, I'll just caution and say that certainly they can be a source of energy if malnutrition is a concern, but the overall nutritional value may be more limited. Now, a lot of these products may be rich, have a rich component of protein. So again, if the concern is malnutrition management, protein and energy coming from these substitutes can be very beneficial. But if one is not malnourished, then I think you can just eliminate milk and not worry about a substitute.
Okay, great. Thank you. So I'm just going to wrap this up. It is almost 8 o'clock. So that's all the time we have for today. I would like to thank both of our speakers. We really appreciate you sharing this information. And we will have the recording up on cdhf.ca sometime next week for all of you to view. So thank you very much. And
thank you as well to CDHF for the opportunity to present with Dr. Raman. And we do thank you for all your questions, and sorry that we couldn't get to all of them, but we just really encourage you to speak to your family doctors and your gastroenterologist because there is marked interest in treatments for inflammatory bowel disease as well as for diet. So thank you.
And I echo the same. Thanks to CDHF for this opportunity. Very much appreciated.
Okay, thank you so much. Have a great night, everyone.